Good morning, Borodar, and welcome, Croiser, to our webinar on shared lives and mental health crisis, which we hope will be informative, engaging, and inspiring. We have lots of speakers to give you multiple perspectives on the work, and there will be a chance to ask questions at the end. So please use the chat function or the Q&A function. You'll see those buttons at the bottom of your screen to post your questions, and we'll pick those up at the end. My name is Benna Waits. I'm Joint Head of Psychology, Counselling and Arts Therapies for Aneurin Bevan University Health Board, and I'll be chairing and presenting this morning. This project has been the result of a partnership between Aneurin Bevan University Health Board and South East Wales Shared Lives Scheme, and we're delighted to start with some brief opening remarks from Welsh Government, whose funding made the work possible. Leslie Singleton, who is not able to be with us today, is a mental health network lead for Welsh Government and has recorded a short message for us. So, over to you, Leslie.
On behalf of the Mental Health Network in Wales, I want to pass on my huge congratulations to the South East Wales Mental Health Crisis Project that was recently recognised in the World Health Organisation's Guidance on Community Mental Health Services. This is a huge achievement and one that everybody involved in that project should be incredibly proud of, and all of us across Wales should be proud of that recognition. The project itself is a partnership between the South West Wales Shared Lives organisation and the Aneurin Bevan Health Board. It's an integrated health and social care project that puts people in the centre, builds resilient communities and focuses on recovery and prevention. All the things that we would want to share that learning across Wales as we look to improve our response to community mental health services. The World Health Organization guidance that was published earlier this year brings together good practice from across the world, and it has a real focus on person-centred care and human rights-based approaches. There were only 28 community services recognised within the guidance and only 3 of those in the UK. So again, this really shows how proud we should be of the work that the South East Wales project has achieved in getting this recognition. I look forward to hearing much more about it. I look forward to thinking about how we can scale this work up across Wales, and I look forward to sharing the success of this project as we move forward. Thank you very much.
Thank you for those kind words, Leslie. It now gives me great pleasure to introduce Alex Fox, who is the Chief Executive of Shared Lives Plus. He also chairs work on behalf of NHS England and is an Honorary Senior Research Fellow at Birmingham University. He was awarded an OBE for services to social care in 2017. And he's also author of this book, A New Health and Care System, Escaping the Invisible Asylum. I can recommend that very highly. I think it's a fantastic book. So, Alex, over to you.
So I'd just like to welcome everybody to the event and say how pleased and honoured we are that the work of our members in South East Wales on crisis mental health support has been recognised by the World Health Organization. And the South East Wales Shared Lives programme is one of 150 right across the UK. The UK is something of a leader in shared lives globally, and actually Wales within the UK is the leader in terms of the numbers per population who are supported within shared lives. So there's some real success here, although we are also very ambitious. We want shared life support to be available to many more people with mental health problems as well as other support needs. At Shared Lives Plus, we're the membership body for both the Shared Lives services in the UK and also 6,000 of the 10,000 shared life carers in the UK as well, the individuals who open up their homes and share their lives with somebody who needs significant support. And to give you a sense of the Shared Lives model, probably the best thing I can do before you listen to Nikita and her story later on is to tell you a little bit about something that my colleague Meg, who used Shared Lives, still uses Shared Lives, said, which always stuck with me. And she was talking about when she lived for several years on hospital wards within the mental health system. And she said the people that looked after her on the hospital ward did care, but when they go home at night, when their shift ends, they had to switch her off and go back to their own lives. And she contrasted this with moving in with her shared life carer, Hayley, where she moved in and became part of Hayley's household, and had that level of care, which wasn't switched off at night, which was there whenever she needed it. And she still has a really close relationship with Hayley now. And that's true of many people that use shared lives and their shared life carers. So it's a model which brings together two worlds which we often keep separate, particularly within the mental health system. We have the world of the personal and the private, what people do in their own lives and communities. And then we have the world of the professional, of the service, and the medical world, people being treated for their illness. And Shared Lives tries to bring those two worlds together. So shared life carers in the UK are they're trained, they're paid for what they do, they're part of a regulated care service that the government inspects. And there is infrastructure and support and structure around that model. But then they are also people that after they've gone through this really extended approval process, which ensures that they're the right person for the role, then shared life carers and the individuals go through a matching process. They get to know each other, they decide whether they're going to be a fit, and that enables them to live in a way that doesn't feel like it's part of a service, to live in a way which feels much more human, in which people who come into, if you go and visit a Shared Lives household, it feels like visiting anybody else's household. It feels like ordinary life. And it's that combination of the professional with the personal, which gives the Shared Lives model its power and which makes it so unusual as well, and sometimes tricky, because so much of our regulation and our laws and how we organize things are designed around a separation between the personal and the professional, the community and the state. So Shared Lives is a model which is now available right across the UK. It reaches 15,000 people. About 1,000 of them are primarily using it as a mental health service. And we'd like that number to be much greater, because obviously that's still, although it's substantial, it's still a tiny fraction of the number of people who use mental health support in total. And we also want many more services to learn from the Shared Lives model as well, which and what we'd like other services to think about when they see Shared Lives working is not just how many more people could benefit from this model, but also how is it different? And it's different in a number of key ways. Through recruiting people, sometimes over a number of months, certainly over a number of weeks, getting to know people really well, and then through the matching process. Shared Lives is able to set up support arrangements which feel much deeper, which feel much more human, which are much more aligned with people's lives, and in which people are supported by somebody who's going to be there for the long haul. Whereas too many of our services throw a succession of strangers at people going through these very long, complex public service journeys. So we want all services to think, how could we get people involved that we knew well enough that we would be able to put them in much deeper, much more longer lasting support roles, and with a view to people actually being able to not just get the support they need, not just be able to meet their medical outcomes, but actually to be able to think about, what does a good life look like to me, and how can we together go about living it. So South East Wales and this service is one example of how you can do that, and we want there to be many more right across the UK.
Thank you, Alex. What an inspiring beginning to our morning. I think you really highlight why this matters and the power of this way of working to transform lives. So I'm now going to chair myself into my presentation. So I'm going to be talking to you about the development and implementation of the Shared Lives for Mental Health project. And really, this echoes, I think, lots of what Alex has been talking about. So essentially, oh, sorry. What I'm going to talk to you about is the ideas, the beginning of these ideas, so how we got there, to explain some of the key elements of the service and share our outcomes. So we have some data, but we also have lots of experiences of the project. So this is the guidance. So you can find it on the World Health Organization website, and it features 28 projects from around the world that are taking a recovery rights, person-centered approach within community mental health services. We are really honoured to be in it. There are another 2 services from the UK that are in there, but from the initial call out, we made it into the final cut. So we're delighted to have the kind of opportunity to share and disseminate what we think is a fantastic project, both in terms of the mental health crisis work, but also the wider Shared Lives service. So for us, where we started with this was thinking about our crisis services and a sense that they weren't working as well as they should for everybody. Actually, lots of people were telling us that things were not fitting together well. They were not well coordinated. They were not responsive. They were not. They didn't feel as if they were offering the kind of. There was lots of room for improvement, should we say? So I guess we wanted to start with the question of what matters to people when they're experiencing a crisis in their mental health. And if that conversation led on to some service redesign, we wanted that to be as broad as it could be. So Alex talked about a whole system approach. So we called it our whole person, whole system transformation process. How can we make sure that service users and carers alongside all our stakeholders are involved in shaping our services? So in order to begin this process, we set up an action learning set. It was quite a big commitment of time. So it was 6 days over 6 months to develop a new service model together. And we had all of these people involved. The International Mental Health Collaborating Network co-facilitated that alongside us in an Aaron Bevan University Health Board. And as part of it, so we had lots of conversations, there were lots of really useful output, some of which I'm going to share with you in a moment. But we also had a look at some other services, visited some other services. So the services in Trieste, which were also featured in the World Health Organization guidance, and also the host families service in Hertfordshire, which was very helpful to us in influencing this particular project. So one of the questions we asked, so we took this big group of people that were working with us and we said, what's important to you when you're distressed and going through a difficult time? So if you look at those words that have come out more strongly, that more people said, what's really striking about that is the humanity, isn't it? It's that sense that these are relational needs that people have when they're in crisis. So I guess the question for us when we think about how do we create services that have relationships at the heart of them, that face-to-face, listen to, supportive experience, what services are going to best meet those kind of needs, and are we doing it as well as we can at the moment? So this was one of the models that came out of that work. So some of the services that you'll see in this model, we already had in place. So our crisis and treatment and liaison teams, our inpatient provision, but we also wanted to put in place, being developed in the last couple of years or about to come online. Very excitingly, we're about to open our first support house in the next month or so. So really looking forward to that. So Shared Lives, you can see down at the bottom there is one element of this whole person, whole system crisis transformation. And that model sits in the middle. So you can see it there in the green circle of what we hope are recovery-oriented services, preventing crises and resilient communities. The overall hopes are to develop services that are more recovery-oriented and rights-based, more truly community-based. And I think Alex talked about this also, this sense of, we have lots of services actually that we've located in the community, in clinics and various places, but actually really using the assets and the connections and the networks that sit within communities, really developing that alongside people. And more co-produced and person-centered. and that place the service user at the heart of our provision. So these are all, I've put more at the beginning of each of those bullet points because it feels as if we've come a long way in services. So it wasn't that we weren't doing any of these things before. There were lots of examples of fantastic practice, but we want to get better at it. And that will be an ongoing journey. It's something we're constantly working to get better at. So this is Shared Lives in Gwent. So what is it? You can see two of our carers, Jane and Martin, there in front of their home. So it offers a recovery-orientated supportive home environment to an acutely unwell service user as an alternative to inpatient admission or as an early discharge. But essentially it's an alternative to hospital. How's it different? So Alex has talked broadly about the main Shared Lives scheme, and there's some really key differences. So funded, lots of the values are absolutely the same, but I just want you to be clear about the differences. So it's funded by health, as I mentioned earlier, through Welsh Government mental health transformation monies, and we have recurrent funding for that, which is fantastic. So funded by health, we have a specialist coordinating team for the work, which is also funded by health, and Emma, who's the who coordinates that team, you're going to hear from in a moment. It's supported by our crisis teams. So crucially, our crisis teams are incredibly active in the support of people when they're acutely unwell, when they're in shared lives. And that joint working is absolutely critical. And the involvement for this project is shorter. So in fact, the stays that people have are generally on average 14 nights, which is roughly equivalent to our average inpatient stay, which is 12 nights. There is an option for longer term. So some people go on to have longer term contact, but actually that's a minority. So this really is an intervention which we're gearing up to be short term. And I think what's interesting as we go on to talk about the impact of it is even without all of the kind of extra ongoing contact over years that Alex has talked about, that shared lives, the wider scheme does so beautifully, just the experience of being with carers for that short period of time and cared for in a different way seems to be really important for people. So far, since our launch in 2019, we've had 73 people who've experienced a shared lives arrangement when they've been in crisis. And in terms of their experience of it, we have something called the Patient Experience Questionnaire that we use, which has a 0 to 10 rating scale, with 10 being excellent. So the average score at 9.19 is really high. So people are rating it as an incredibly positive experience. We have quite a bit of data. So we used a measure called the Recovery Quality of Life Scale. That's looking at scores as people enter a shared lives arrangement and then their scores when they finish. And you can see from that diagram that the scores increase really significantly. And when you put that through a statistical significance test, p less than 0.001 is a really high level of significance. So it's a reliable and clinically significant difference. We wanted to make sure that this wasn't just a feature of people's recovery journeys. So we were able to compare with a group of matched controls prior to implementing shared lives. So we took a group of people that would have been, we would enable to access the scheme prior to setting up. And you can see there that people do improve on their REQOL scores whilst they're on an inpatient ward, but the difference is markedly more significant on in a shared lives arrangement. We also looked at the impact on admissions. So a number of people who use our services might have repeated crises. So admissions pre and post a shared lives stay. So 90% of the people going into the scheme show a reduction in their admission rate. And you can see here, so this is a slightly complicated chart. So it's looking essentially at people who've used it over the last year. And it's comparing their period after. So if they went into a shared lives arrangement 10 to 12 months ago, it's comparing it with the 10 to 12 month period before that. So you can see that on the right hand side, and then similarly 7 to 9 months, 4 to 6 months, and 0 to 3 months. So each person is functioning as their own control. And you can see there's a really dramatic difference in what's happening with admissions. There's also something really interesting, I think, about onward referrals. So this is people's use of the mental health services pre and post a shared lives arrangement. So these will be things like referrals to a psychiatrist, a psychologist, an occupational therapist. So it's use of services, and you can see that there are marked reductions for people after they've used a shared lives arrangement. And we might have some hypotheses. I guess we could all think about why that might be, but that might be about improved networks, about improved recovery rates. All of these things feel as if they connect up. And it's worth thinking in this context in relation to both admissions and onward referrals about the cost avoidance that this is generating for us in health. And that's a really big part of why we're funding this. You know, we want better outcomes for people, but we know that that will pay back over time. So yeah. So what's much more powerful, I think, is what people say, and you'll be able to hear from Nikita and Mags very soon in terms of their experience of this. But these are lots of the quotes that we've collected over the time that we've been running the project. So these 3 quotes relate primarily to what we would call activities of daily living. So a sense that, so this gentleman at the top was in a shared lives arrangement and learned to cook while he was there. So that wasn't the result of a kind of occupational therapy intervention. That was just being in a normal family home and having the opportunity to learn to cook, and the impact that that had for him on going home and feeling like a proper dad. This sense, I think, in the orange quote is really interesting about some of the stuff that gets risk assessed off inpatient wards. So that notion, and Nikita will talk about this later in the video, the notion of kind of cutlery drawers with knives in them. The quote in the pink here talks about ironing. You know, these are not things that you have ready access to on an inpatient ward. And the risk, I guess, that the absence of those things is in some way potentially dehumanizing. So that sense for this person that being around all of those kind of normal things felt that they were being treated like a human being. The woman who did the ironing, that was our very first person who entered an arrangement, and it was huge for her. It was absolutely huge. It was a really big part of being able to recover, was having access to ironing and how that made her feel. This next handful of quotes, so there's something about the peace and quiet. I think a lot of us, when we think about going through hard times, talk about peace and quiet and how important that feels. That notion of sanctuary is often very a peaceful notion, isn't it? And I am aware that it's really hard on inpatient units to kind of create that sort of peace. So lots of people talk to us about how valuable it was having a quiet space and the calmness that comes with that. This quote on the left was from a husband of somebody who entered our shared life scheme. So talking about how powerful he'd originally thought that shared lives wouldn't be enough. There's a lot of anxiety around, you know, when people are acutely unwell, there's a lot of fear, a lot of concern about risks to the person. So he was concerned that shared lives wouldn't be enough. And what he says is, by the end of the 3 weeks, my wife actually came out for a meal with me and our son for his birthday, which is something she wouldn't have done in public before this stay. I think it worked because it gave my wife a chance to see how another ordinary family operated, and some of the pressures she was feeling are perfectly normal and understandable. So you have a sense there of the kind of normalizing, validating impact of living with another family. So this is a bit, these 2 quotes both relate to the kind of relational power of this setting for people. So a sense of kind of having somebody there to talk to. As nice as some of the ward staff are, they just don't have the time to talk to me and listen like the carer did. That's all I really needed, time and reassurance, which echoes, I think, a bit that early slide that I showed you with a kind of what do people need. And finally, that sense of community reintegration. So being able to go back and visit your house on a regular basis, building up your confidence to be back in a sense of normality. There's less of a kind of massive difference between the ward environment and coming back home because you are in somebody's home. So in conclusion to our quotes, this sense of the experience being life-changing. So remember, we're talking about a stay that was on average 14 days. It has been life-changing life-changing for me. And if this had been around years ago, perhaps I wouldn't have kept coming back onto the ward every few months. Thank you for helping me feel like me again. So I think those are really eloquent testimonies really to the power of this work. So if we're inspiring you, and you'll hear more from Emma about exactly how this works soon, but here are some things that you might want to be thinking about. So it's critical to engage your crisis teams and medical colleagues. Shared Lives can't do this particular work on its own. And as Alex says, that whole system approach is really important, but having your kind of health colleagues on board is critical, and building relationships between them. So this has worked because of the relationships that have been developed, where the people within the partnership have high levels of trust of each other. Supporting a culture of positive risk-taking and psychological safety, that's particularly important for us in health. Remembering that our inpatient environments are not risk-free. So we're not comparing environments that are entirely risk-free with an environment where stuff can happen. Things happen on our inpatient wards. So it's important to hold that in mind when you're having these conversations, when people are feeling concerned about it. And promoting the World Health Organization guidance. I'm hoping there'll be other opportunities in the future to share more of the amazing best practice examples that are in there. But as a culture changing document, it feels really powerful. So I hope those are some kind of ideas and pointers, and please feel free to ask us more questions at the end. So these are our contact details, and we'll have these available on the website for future use. So don't worry if you don't catch them now. Emma, over to you. Emma is our crisis project manager on the scheme, and we work really closely with her. So over to you, Emma.
Thank you. Morning all. So I'm Emma Jenkins, and I've worked with the South East Wales Shared Lives scheme since the conception of the collaboration back in 2012. And I was very proud to be appointed as the manager for the Mental Health Crisis Project in 2019. And it's been my absolute privilege really to work so closely with the home treatment teams in developing what has now become an established service for mental health across Aneurin and Bevan. And very proud to be recognised by the World Health Organization for our efforts in getting this service up and running. It's absolutely remarkable. I know Alex has given you an overview of Shared Lives, but I think this quote really sums up the ethos for me. It's to provide an ordinary family life where everybody gets to contribute, have meaningful relationships, and are able to be active, valued citizens. And that is our goal within Shared Lives, to achieve those. So a bit more about the South East Wales scheme itself. So we are a partnership across Blaen y Gwent, Caerphilly, Merthyr Tydfil, Monmouthshire, Newport and Torfaen. We are the largest scheme in Wales, and it says that we provide over 400 arrangements in over 200 households across Gwent. And we provide arrangements for any adult, so anybody over the age of 18 with an identified support need. And that can include a variety of support needs: learning disability, dementia, physical disability, and mental health in this particular instance. We are a large team, as you can imagine, to be able to effectively manage all of those arrangements, and we're very happy to continue growing. As I said, our admin team are the absolute crux. As anybody will appreciate, without an efficient admin team, a service can't function. So I'd just like to thank them for all their continued support. So Shared Lives basically is whereby a carer and an individual who need care or support share their home, family and community life. And it's really that human element that for me makes Shared Lives just so different to other services out there. Within South East Wales Shared Lives, we've expanded quite greatly actually. So individuals accessing our service can receive a variety of support. So that can include daytime sessional support, short respite stays, transitional periods, periods of assessment following hospital discharge, emergency support, or they can live long-term permanently with carers. Our carers are remarkable. They are recruited from local communities, just you or I. They provide arrangements from and in their own homes. No formal qualifications are necessary for our carers. That's not the point. It's their life experience and their willingness to learn and share and just care, really, that makes them who they are. They will undergo a thorough assessment with us. It takes roughly around 3 months. The usual checks, DBS, references. They undergo a health and social care induction. And at the end of the assessment period, they are taken to an independent panel where hopefully everybody is satisfied, and then they're approved to commence working with us. They receive ongoing training and support and supervision then from our scheme. And we really do encourage training, ongoing professional and personal development for all of our carers. As Alex mentioned earlier, the scheme is regulated. We're registered and inspected by Care Inspectorate Wales. And they obviously are in touch regularly in order to make sure that we are fulfilling all of our roles in line with regulations, that we're assessing carers, monitoring arrangements effectively, and meeting all of the required standards. Just to give a flavour really of the numbers involved, here are the figures from last year. And to me, knowing how Shared Lives has developed over the years, back in 2012, the long-term percentages there would have been perhaps even way over 2/3 of the chart. But for me, this is a clear indication that our collaboration really has developed into more of a preventative model, whereby the sessional and respite services are now being utilised to enable individuals to live with their main carers, be that their family, within their own homes for a longer period, really. And we utilise the session and the respite to just give that community involvement and the main carers a little bit of a break. And for me, what is remarkable in these COVID times is that the emergency referral rate really shot up last year. And I think that's a reflection of COVID, as many of the referrals were as a result of carer illness or family breakdown. And we were able then, our carers were wonderful and able to respond even in a pandemic. So as a collaborative scheme, we sort of recognised that there was scope to develop and widen really the use of Shared Lives. And hence in 2016, we gained Welsh Government funding to launch a health initiative project. And the objective of that project was to specifically look at, and this is from a social care context, was to look at referrals that prevented hospital admission, be that physical or mental health needs, support timely discharge, offer periods of assessment, and really focus on working with individuals with dementia, mental ill health, and end-of-life care. That scheme is still up and running, that project within the scheme. We've received nearly 500 referrals, 2/3 of which have progressed to successful arrangements. We've had to recruit new carers to specifically work with those referrals. And as you can see with the figures, a large majority of those referrals are working with individuals with a mental health diagnosis. But this is from a social care context. But what did happen then is that Health Initiative project then set the groundwork and was the blueprint really for this project's development. And in April 2019, we signed a service level agreement with the Nairon Bevan Health Board to specifically provide Shared Lives arrangements for those people experiencing a mental health crisis. The project has run for 2 years now, and due to its success, we've recently been extended with recurrent funding and expanded to cover the whole of Gwent. So as Benna mentioned, we provide arrangements. It can be up to 4 weeks, but typically it's averaging sort of 2 weeks for people who've had an inpatient stay and are recovering, or as an alternative to inpatient admission initially. in this context, Shared Lives is an opportunity for people to have a different experience in crisis. And I think when we speak to Nikita shortly, she will testament to how that can differ from a hospital environment. It offers more choice to both individuals and the staff. And this service is fully supported at senior levels within the Health Board and the local authorities. So how does it work? Myself and my colleague, we as the Shared Lives team within mental health crisis, we work really closely with the crisis home treatment teams. As Benna mentioned, those relationships are absolutely critical in getting this service to run effectively. So we base ourselves physically within the home treatment teams throughout the week. We sit in, attend board rounds, make relationships with the consultants. The ward staff are aware of us. So we've really developed that rapport, that trust, and we've built that over time. So the crisis home treatment teams would identify a patient that's suitable for Shared Lives, and they refer that person to us. It would be then my role then to go meet with that person on the ward, to have a chat with them, answer any questions or queries, offer reassurance. I often use the YouTube video of Nikita, actually, if they have any concerns. I'll explain and say, you know, we have a patient who's previously used the service. Would you like to hear their thoughts and feelings? So that's a really good educational tool. And should that person then wish to go forward with the service, I will gather much more information about them, the personal information, what matters to them, to enable me then to commence the matching process to identify a compatible carer and household. And within that matching process, as Alex briefly mentioned earlier, I'd look at the person's hobbies, their interest, any cultural preferences, the location of the carer's home. Would they prefer rural or urban? Are they looking for a quiet environment? The household dynamic, you know, are there children there, pets? You know, pets are so important. And the makeup of the carers, if they're male, female, a couple, single, do they work, are they retired? And so we can really get a good feel for what is going to be the suitable environment. And once we've identified that carer, our household, we arrange for introductions to take place. And this can either take place at the ward or at the carer's home, whichever the individual feels more comfortable with. And it would be then Shared Lives' role then to facilitate that introduction. And if both parties agree, then the arrangement can actually start immediately. So potentially, timescales wise, the arrangement could happen the same day as the referral. And that was happening much more frequently before COVID. As you can appreciate, there's requirement for a negative COVID test from discharge from the ward at the moment. So that can add, you know, a further few hours whilst we're waiting for that to be processed. But many of our arrangements can start the same or the following day. So it's really reassuring for somebody, because the patients explained to us, the last thing they want really is to build the anxieties build about going somewhere new, and then all of a sudden then they're waiting for 2 or 3 days. That's not helpful either. So we like to really go with it. And although we work really closely with the home treatment teams and hand in hand, and we have a wonderful rapport with them, we have really defined roles, and it's very important. Really, our operational processes really highlight the specific roles each of us undertake. And the crisis team role really is to support the individual, whilst the Shared Lives team support the carer. So the crisis team would, as it says there, they'd risk assess the individual, they'd share all the pertinent information with Shared Lives prior to the referral. They'd regularly visit, they'd support goal planning with the individual. They're responsible for discharge planning and then for connecting up any sort of multidisciplinary input required. Whilst Shared Lives, we match, we identify the carer. We then develop a personal plan with the individual, which really identifies the support needs of the person, but also the outcomes, the goals, what's important for them, and how they would like the carers to support them in achieving those. And we monitor that then throughout the whole arrangement. We have regular visits, and some of those visits are coordinated in line with the home treatment teams, and we undertake joint. And we also offer a 24-hour on-call support service to our carers via our on-call management team. And that's actually really critical for the carers to know that in the middle of the night, if something happens, if there's a query of something, then they also, obviously they have access to the wards and to the clinical staff, but they also have access to us on call for that support as well. And as well as then the ongoing monitoring and development of our carers. In this particular instance with the Mental Health Crisis Project, we gather the evaluation data for both the individual and the carer throughout the arrangement. As Benna mentioned earlier, our individuals will identify goals that are important to them and how they would like these to be met throughout the shared lives arrangement. And we then monitor and review this at the end of the arrangement. Now, many of the goals that have been identified over the last 2 years have similar themes, and they range from increasing confidence, gaining more independent living skills, domestic house tasks, budgeting is a big one, as well as sort of medication management. And these are, when you look at these goals, they can appear to be quite simple, and many people may take them for granted, but a little bit of support and encouragement and developing confidence in these areas can really have a massive impact on somebody's life and supporting their recovery. And so it's really actually really rewarding when we review these at the end of an arrangement and we mark the scores, and if an individual feels that they've achieved or partially achieved meeting that goal, it really is rewarding, and that's then fed back to the carer, obviously, as they offer that level of support. And the analysis for the evaluation then is fed back then to the health board, and the data is extracted, and that's some of the figures then that Benna shared with you earlier. And that is my presentation complete. So thank you.
Thank you, Emma. That's great. Now, Alex, I understand you have got access to the video and you can share it with us. So would you like to have a go at doing that?
My life was a really dark place, and well, my mind was more than anything, and I didn't see a future at all. And I guess what being here has taught me is recovery is an option.
My role in Shared Lives is to offer a place for someone that has and is in crisis for mental health, that has spent time in hospital, and they don't think the hospital may be the right place to continue the treatment, but they need somewhere to go to continue the recovery. And my role is to have someone come to my home, live with my family, offer them support, understanding, and continue their treatment.
I was really overwhelmed at first. I didn't think this program would work for me and that I would end up back in hospital, but it's proved to me that's not the case at all. And I have so much stability here and security. Mags has just given me routine, day-to-day life, and helped me with things that I can't manage yet, but hopefully I will in the future.
When Nikita first came, she needed a lot of support. But as she settled in, as she got to know us, as she got to understand that we understand her needs, that becomes more relaxing, and she's able to concentrate on recovery, which is why she's here. And then hopefully move on to independent living eventually. And yeah, that's the goal.
Oh, me and Mag's got a great relationship. Yeah, we do lots of walking. She even helps me with my university work. If I'm training for a half marathon at the moment, if I don't go for a run, she, like snaps me back into that routine. You haven't had one today. It sort of prompts me with things that I need to be successful. Since being here, I'm able to focus on, the more practical things of my life, university and running. And I think that's because Mags has given me more confidence that I can succeed and I can do these things that I used to do when I wasn't unwell, and that it's just a stepping stone,
She's going to be so successful. I wanted to go and fulfill her potential, which is so much of, and I know she's going to do that. That would be fabulous. Yeah, and I'd smile inside and out because she's a beautiful, lovely girl. She's so intelligent and she's got so much, and life's gonna be fantastic for her. I know it, absolutely.
If someone believes in you more than you believe in yourself, it gives you more motivation to succeed in whatever you're doing, and that's what I've got here. I feel hopeful and I'm giving myself a chance, and that's scary, but I feel okay that I'm making that decision now, that I'm not set on another way of life or another way of not having a life.
That's fantastic. Thank you, Alex, for finding that. I'm so glad we were able to share it. And it's the perfect segue into Nikita Filer and Mags Evans, who are going to be in conversation with Emma. So if I can hand over to the three of you.
Thank you, Brenna. And I'll just explain, as is current times, that Nikita and Mags are in a COVID secure bubble. So that's hence they're able to sit together today for this question and answer session. So I'll ask them to introduce themselves, and then we'll make a start. You happy to just, I know Ben has given your names, ladies, but are you happy to just, so we can hear your voices?
Yeah, Mags Evans, I'm a Shared Lives worker, carer.
Nikita Filer, and yeah, I was a patient in St Cadoc's Hospital.
Thank you both. So can you tell us a little bit, Nikita, about what was life like before Shared Lives for you?
So before Shared Lives, I had no fixed abode. I had no address. I was always going back to A&E when I hit crisis, and I was just completely hopeless. And yeah, I was just constant assess and try and diagnose the problem, but the treatment wasn't working, regardless of me having a CPN, and I was still feeling really awful and suicidal. So.
And what did you first think of Shared Lives when you first met me and I told you about it?
Well, I had no idea what it was first, and I was pretty apprehensive because I just never heard of anything like this in my life. So when you came up to me and told me I could go stay with someone instead of being on the ward, I guess I was nervous, but when we went to Mag's house, I knew that was a great opportunity for me to grow, and so much better than the ward.
Thank you. Yeah, because you felt introductions at Mag's home was better for you than Mag's coming to the ward, didn't you? So I took you up to meet with Mags. And what did you feel about that, Mags?
Well, before someone comes to the house, I would have had some paperwork and I would have had discussions with my Shared Lives worker.
But it's not until you meet the person that you really, it becomes real. Yeah, you can get an idea from paperwork and from talking about someone, but until that person sat in front of you, that's when it becomes real. It's the initial meeting, I think. Now, the shared lives worker will have will know my strengths and my experience, and they will have matched up an individual that they think that I can work with, which is like really important. But the initial meeting of the individual, I need to be able to quickly establish a connection with that person, to see if I can work with them and see if they want to work with me. And I guess I think the most important thing for me is to just show mutual respect to that individual.
Did you both get that feeling when you met that first time in those introductions?
Definitely. Yeah.
Yeah, I get this. You get little odd conversations with each other in between, like this sort of official meeting and the paperwork, what have you, and that's when you sort of like really get to know that person. Yeah.
So, why do you think that shared lives is an important option to be available for others then in mental health crisis?
I think it's really an important opportunity because the ward can't offer you the same amount of attention, one-to-one attention. They've got limited resources, and you can't do a lot of activities on the ward that would promote your well-being after your stay there, like cooking or going walking, seeing your family and things like that. Really, so much quieter and just great to be able to get outdoors with someone, support, and you're not restricted to that environment.
And what about for you, Mags? What sort of feedback have you had from? Because I know you've provided a few arrangements for this project.
Yeah, I have been lucky enough to provide a few arrangements, and I think what the important option for people is in shared lives is like a therapeutic placement, and it's one-to-one. So you can give them as much time as that individual needs, and I guess it does free up space on the wards. That's another thing. I think as well, you've got time to introduce the individual to community stuff and offer activities tailored to what their needs are and what their likes are, or their interests, whether it's educational, learning a new skill, independent skills, exercise, anything like that. And I think I've had some really positive feedback from people that I've had through the scheme, and they've said it's been a genuinely positive experience, and it is a much better option for them than staying on the ward that much longer.
Thank you. And how do you feel it's helped with your recovery, Nikita?
Oh, massively. When I was at Mags, I was able to do my university work on my laptop. So, I mean, even at the ward, I couldn't go on my laptop and do that. So I was already behind on that.
And was that making you anxious, falling behind with your studies?
I was like increasing my anxiety so much. And yeah, definitely. I was able to do so much more, and now I'm volunteering in 3 different places. So I'm able to adapt more to community life and just have so much more confidence as well.
Do you feel that the environment, the location of Mag's home setting helped?
Definitely, definitely.
Yeah, because it's quite rural there, and you have a lovely garden, Mags, don't you? That many
Yes, my garden.
individuals who stay with you find that to be a huge benefit, don't they?
Yeah, they do, because I've got quite a lot of interests as well that I can share, whether they want me to share with them or not. I can share with with individuals, whether it's gardening or sports or whatever it might be. And people are quite up for being introduced to new things, whether it's books, whatever it might be. You know, that not everyone has got the same interest, so it's like refreshing when they come to someone's house and they've got interests that they've never had before, and they genuinely like being part of it.
So Nikita, you said you were training for a half marathon there in the video. How did that go?
Yeah, it was great. So I did that just after I left Max's, I believe, not long after. So that was a huge achievement for me. Just being able to run when I was at Max's was phenomenal, and where I couldn't get that on the ward at all.
There's that access to exercise, fresh air, nature. Yeah.
What was it? A half marathon or full marathon? Half marathon. We went. I went to watch her at the finish end, and met up with your dad, wasn't it? Yeah. And we cheered her in. It looked hard work, really hard.
So it's quite obvious for us to see that you've formed this sort of friendship that's developed after the arrangement, and that's something that's very much both of your decisions. It's not something that's mandatory in the service, or it's not something that's not condoned either. It's very much a case by case, and that's something that developed quite naturally to you both.
Definitely, yeah.
Yeah, that's right. We've got quite a lot of interest together, haven't we?
Yeah.
In a way, you know, sports and things like that. We're interested, and when someone comes to your home, like I said before, you're showing it's mutual respect to that person, and if you're helping them along with the journey, that's fine. But they're a human being, so you know, if you get friendly with someone and you like them and you want to carry on afterwards and support them, or just be a mutual friend, I mean, we think that's fine.
Thank you. And what are your plans for the future, Nikita?
To be honest, I'd like to go back into work, carry on volunteering, and I'm just started living independently about a few months ago now. So, I mean, a lot has changed since that video, but it's all positive. Yeah.
Wonderful. And I know that you're still linked in with Mags and us as a service from a promotional aspect, really, and raising awareness and education. Do you want to just say a little bit about that?
Yeah, definitely. I think it's important for other people to know in the future that this can happen. It's not an option for me to even go back to hospitals. It's not something that will happen, I don't feel. I think it's important for other people to know the awareness of shared lives.
Thank you. And I'll just add there for everybody else's benefit that Nikita and Mags are both members of our operational group. So they have an ongoing input into the development of the service, and their views are very much appreciated and taken on board with any decisions that we made. So they're integral to that and our future development. So I want to thank you both for your continued support and promotion of the scheme, and for allowing us to pick your brains and at times like this to share your story with everybody. So thank you very much.
Thank you.
Thank you.
Lovely. Thank you so much, Nikita, Mags and Emma. That was really helpful. Now we're going to hand over to Catherine Morgan now, who's going to talk a bit about Shared Lives Plus. So Catherine, over to you.
Thank you, Verna. Hello, everyone. Well, that was so inspiring, and I've seen that short film clip, but that was so much better to listen to Nikita and Mags like that. So how do we make this happen in other parts of Wales and indeed the UK? So I just wanted to share the first email that I received from Dr. Michelle Funk from the Department of Mental Health and Substance Use, World Health Organization. I had quite a shock when I opened the email, but it spoke to all of us about a different path that people take to receive support for their mental health, and a different path for those people who are trying to use existing systems but know that there must be a better way. So we've heard today how the South East Wales Shared Lives scheme, the Mental Health Crisis Project in Gwent, is offering people that different path to recovery. It's offering them hope, a vision of a better future, opportunity, new goals, and more than anything, a loving, caring environment in a family home where they can feel safe and have a sense of belonging and feel valued. We've heard evidence from Bennett today of what happens. When you build a model of regulated social care around ordinary family relationships. So as Alex said, there are now nearly 15,000 people living or visiting Shared Lives households in the UK, and the support they receive can be short-term or more long-term living. So how can we ensure that more people like Nikita and Meg that Alex spoke about are given the opportunity for recovery in their own community with that personalised, tailored support? And how can we ensure that more people are able to describe their lives by telling us in their own words that we saw on Ben's slides? So this has been life-changing for me, being given time and space to recover. I felt like I started with a clean slate and was trusted to just be me. So Shared Lives Plus is the UK membership organisation for Shared Lives carers and Shared Lives schemes like the South East scheme that we've heard from today. So we can help start those conversations, negotiations, break down barriers. We can provide evidence-based reports, those real life stories, and showcase asset and human rights-based approaches that achieve better outcomes. So from what you've heard today, if you're interested in starting a conversation, interested in partnering with a Shared Lives service and a health board, talk to us at Shared Lives Plus. We offer a range of bespoke strategic support services, which will help organisations develop or diversify shared lives in their area. We've worked with local authorities, NHS, commissioners, and Shared Lives providers. I just wanted to share with you one or two slides today. So Shared Lives is growing, 42% growth over the last 5 years in Wales and 30% in England. It's consistently rated as the best quality and safest form of social care by the regulatory bodies. So we know it has significant potential to transform individuals' lives and enable society to become more connected. There are over 150 Shared Life schemes across the UK and 8 well-established schemes in Wales. So who are the people that we support? Alex touched on it earlier. This list has grown. People with mental ill health, care leavers, domestic abuse survivors, you'll see there. But not every scheme is able to offer such a diverse service. So how do we do this? Well, Shared Lives Plus is the expertise to support expansion of shared lives. We can provide a range of bespoke strategic support services, which will help organisations develop or diversify shared lives in their area. So we can provide services like a business case. We can provide the necessary business intelligence to make an informed decision about the development, diversification and expansion of a shared life scheme in your area. An analysis of how shared lives will, with strategic priorities for adult social care and housing. So we can provide an analysis to identify the potential availability of shared lives carers in particular areas. And we can provide a multi-perspective review of existing local shared life schemes to understand people's experience of using, working in and referring to the service. You can see their communications and marketing support for any new services that are set up. And we can indeed help with the setting up of a new shared life scheme, should that be needed in a particular area. So this is James and Andy, who also share their lives. And this is what a different path can look like. People who are thriving and enjoying life. At Shared Lives Plus, we'd like to see even more people sharing their lives, able to live in a place of their choice, time and space to recover and be supported to achieve their own well-being. And as it says there, from complex needs on paper to simple goals in real life. So do please get in touch with Shared Lives Plus. We're here to support the development of services like the Mental Health Crisis Project in South East Wales, and we'd love to see it in other parts of Wales and across the UK. Thank you.
That's lovely. Thank you, Catherine. So that brings us on to our Q&A session for our panel. And I think we'll start with a question from Kerry about whether there was any, so this is for Emma, I think, whether there was any bespoke training that you needed to offer for carers as part of this project.
So all of our carers have undergone the mandatory training as part of the Health and Social Care Induction, Kerry. But in addition to that, they also undergo mental health first aid training. And we have ongoing carer support meetings where we have guest speakers from the health board. Then we may have Benna or one of the home treatment team managers who come in and offer our carers then sort of their views and perspectives and answer any queries that our carers may have. But there is no specific bespoke training that our carers utilise, as Mags is really well trained and has a thirst for knowledge and continues her own personal development. But to enable her to support people so successfully as she has, Mags just uses her human skills and her life experience. And this is what we find with many of our carers. They've supported friends, family, work colleagues through a difficult time, have just been a ear to listen, a safe pair of ears to listen, and offered somebody time and space. And we found that that's been, to be honest, very effective.
That's great. Thank you, Emma. And this question comes up quite often, actually, doesn't it? And I think what's really interesting is there's an expectation that carers would need specific training in mental health. And exactly as Emma says, that in fact, what we're relying on is the carers' compassion, humanity, and that actually is what's needed. And I'll from crisis teams going in, people to respond to questions. So a couple of questions. I'm going to move on to Linda Woolley, who had lots of questions, so we'll whiz through some of those. There was a question about whether we're moving people straight from the community, which I can answer very quickly. So it was always our ambition to make this scheme available for people really quickly. So from crisis assessment to being placed in the scheme. And we're getting to the point where we've got nearly half of our arrangements that happen in that way. So you're assessed by the crisis team, and an arrangement happens very quickly immediately after that, without people needing to come to hospital. When we started, we were more cautious about doing that for lots of reasons. So we're hoping that as time goes by, that will be what more and more of our arrangements look like. There's also a couple of questions about, something about suitability and criteria, which I'm happy to pick up, although Emma, if you want to jump in, please do. So essentially, it's interesting, the host family scheme in Hertfordshire, when we visited them, had criteria, and we looked at that and we talked about it along with our service users who were helping us to plan the service, and ended up feeling slightly uncomfortable about that process. So actually what happens now is a conversation with the crisis team and the service user. The crisis teams do make clinical decisions about people that they feel will benefit from a shared lives arrangement. So it's not routinely available to everybody, but where the crisis teams think it will work, they will absolutely offer it. And that's based on their clinical risk assessment, decision making and so on. So it's very carefully thought about, but we don't choose to put it in a list of criteria because that hasn't felt like it reflects the kind of nature of the conversations that happen. Is that fair to say, Emma?
Yes, very much case by case, as Ben has said, and it really is about that matching process then, and we will take the information from the crisis team nurses and present that to the carers that we feel have the right skill set to be able to work successfully with that person, and the carers then are able to make the decision, and quite often we will have a three-way conversation where the nurse who knows that person the best will speak to our carer also and share some additional information that perhaps is not in the paperwork to offer any reassurance or answer any questions or queries.
Yeah, absolutely. I've got a question. There's one from someone about the financial model and also about crisis team and whether they have additional staffing. So I might pick up both of those together, and then we'll come on to a question about when it hasn't worked, which I'll offer up to you, I think, Emma. In terms of additional staffing, yes, we have provided a small amount of additional staffing to our crisis teams to make it work. And from a financial model point of view, I'm not sure if the question was, so I haven't got the details to share with you. As I said earlier, it's funded by Health, so the scheme is commissioned by the Mental Health and Learning Disability Division within Aneurin Bevan. So at present, when we do our calculations around adding up what this service costs compared to inpatient care, it doesn't look like, when you factor in all of the additional costs, it doesn't look on the face of it, if you just take the cost per week, that it is cheaper than inpatient care. But that wasn't really the reason we were doing it. We were doing it because we thought it would be better. We thought it would be better for people and their families. We thought it would give them better experiences, and we hoped that that would lead to better outcomes. And that absolutely seems to be the case. And of course, the thing about getting better outcomes, as I said earlier, is that there is cost avoidance within that. So all sorts of things happen when people, when you support people's recovery journeys better. So they're less likely to use hospital services, they're less likely to use other services. And we're not at a point at this moment in time where we've been able to calculate those cost savings. So I hope that kind of attends to that question about the finance. Question about when it hasn't worked, and actually it's been incredibly low numbers, I think, in this group of people where it hasn't worked. The question was, how do you support people so that it's not detrimental either to the person or to the carer? I don't know if you want to pick that up in terms of how that's been addressed.
Yeah, of course. We have had a couple of instances where the arrangement has had to end earlier than planned, and I would say the majority, and there's literally less than a handful, and there have been instances whereby the crisis team have utilised shared lives instead of somebody coming onto the ward. And of course, then there's close monitoring, and perhaps after a night or two, once the home treatment team are visiting and having feedback from the carer and from ourselves, and it's quite evident that perhaps the individual's mental health has declined, and then it's most appropriate then for them to actually come into the ward rather than remain in shared lives. So it's been an opportunity to try shared lives, something different, rather than the ward environment. And it could well be that the individual, in the two instances I'm thinking of, the individual has said that they would prefer to try shared lives and give that a try first, but their mental health has declined, and so they've been assessed further and needed to come then into the ward. But I wouldn't look at that as a failure, and that's the way that we feed back to both our carers and then to the individual in due course, when they're feeling more stable, is that we tried it as an opportunity, as an alternative, and it may be that it wasn't right at that time, but in the future, it may be the right service for them if they are in that position of crisis again in future times or months.
That's great. Through the chat. Either of those are fine, and we're keeping an eye on both of them. Government policy and how this should, I guess, thought about. And I wonder, pick this up scheme more broadly, because of course in relation to our evaluation, which is quite an intensive use of kind of staff time to support these placements, that's slightly different, I think, to the wider picture. I think Alex referenced this earlier, but do you just want to pick up that question around government policy, Catherine?
Sorry, I lost your connection then, Bennett. Could you repeat that question for me?
So sorry, yeah, just about government policy. So we had a question earlier about how government policy should be impacted by shared lives and these kinds of developments. I was clarifying that the costs for our specific bit of the scheme are probably higher because it's quite intensive in terms of the staffing that we put into it. But I know there's some data around savings in the wider shared lives scheme and how that might, how that should be impacting government policy more widely.
Yes, we have done cost comparisons previously with several councils. They are consistently showing shared lives is around 30,000 lower cost per person per annum. And we're asking councils and governments to invest in shared lives for its better outcomes, as you talked about there, Benna, and on an invest to save basis. So, you know, we've heard evidence there of family homes as opposed to care homes. This can form part of the strategic analysis provided by Shared Lives Plus that I talked about earlier. We look at those cost savings, and we can access the cost avoidance that you talked about earlier with regards to the additional A&E, trips to A&E, the ambulance service, GP appointments, fire service, etc. Some of those graphs explain very, very well how the reduction in all of those sort of emergency services being involved, and that has an ongoing cost effect, hasn't it? So at Shared Lives Plus, we work with government, we raise awareness. Recording this webinar, this will be shared widely to the new mental health policy minister in Welsh Government, as well as with Eluned Morgan. So we're doing our best to make sure that this fantastic service is shared far and wide and will be replicated.
Lovely, thank you, Catherine. And just for clarification, so there's a question about whether there are any costs to individuals using the service. There absolutely are not. So just to be really clear about that, so carers are paid a weekly rate, but individuals, it is essentially like receiving NHS care. So yeah. Now I think, unless I've missed any, I think the remaining questions for us are around whether we can share the presentations. I think that's come up at least once from today. So I'll need to check, because we hadn't discussed that in advance, but I suspect we would all be happy to share our PowerPoint presentations, so we can email those out to participants. The other thing though to be aware of is that this webinar, we hope, will be available as a recording for you to refer people to. So if you've gone away and you want to think about doing more of this and you'd like people to understand it, it should be available in its entirety for you to watch on the Shared Lives Plus website. So watch this space, but we're hoping to get it up there as a resource for people. So I think there's probably, let me just check before I make some closing remarks, but is there anything from any of my fellow panelists that anyone wants to say before we finish, or wants to make me aware of just before we stop? So Catherine, Emma, Nikita, Mags, anything that I need to highlight before I finish?
I don't think so. I was quickly scrolling through it to check we've answered all the questions, so hopefully we have. But if not, people can get in touch.
That's great, absolutely. You've got our contact details in the PowerPoint. So yes, it's just really a huge thank you. I want to start by thanking Nikita and Mags. I think the whole business of presenting and webinars, it's a very it's quite a challenging thing to do. really sure this is a first for a number of people on this call, but I know it is for Nikita and Mag. So I want to thank them so much for talking so beautifully about their experiences of it. And it's so lovely, as Catherine said, that sense of the film has been a huge resource for us in terms of sharing the word, but actually to hear in a bit more detail from both of you about how it's been, and to see where you are now is just fantastic. So thank you so much for doing that for us together. I want to thank Emma for actually just all of her amazing work with this project, Catherine and the Shared Lives Plus team for hosting this webinar and being up for doing it. We've pulled it together relatively quickly. We were really keen to do it off the back of the World Health Organization launch last week. So delighted to have been able to do that this morning. And thank you to all of you for making the time to come and join us and hear about this. We really hope it will, we hope it will spread and share, and that there will be little bubbles of Shared Lives for Mental Health Crisis in other places, and hopefully it'll be easier for people to set it up because of the experiences that we've had and that we've shared. So thank you so much for being with us, and with 2 minutes I'm gonna finish off early and give you the gift of 2 minutes on this sunny day. So I hope you get to move around and stretch, because we all spend a lot of time locked on our screens, don't we? But thank you so much for being with us, and goodbye.